Good morning, colleagues. My name is Hristo Angelov, and I'm from St. Ekaterina Hospital in Sofia, Bulgaria. I'd like to express my gratitude and for the opportunity to present you that topic on that event. Aortic stenosis and left main stenosis, actually, according to different data from different registers and studies, coronary artery disease, frequency of coronary artery disease is between 55 to 81% of the different groups that are observed, and the left main disease specifically varies between 15 and 22% in the different papers and registers. So it's not that rare that we see. Usually those patients go for bypass surgery and surgical aortic valve replacement, but for high-risk patients, they're kind of they have really high risk for those procedures, and what actually we can do and what's going to be our strategy. According to consensus document published this year in June 2024, left main is the only lesion that it's suited to be treated no matter if there is angina or no, because if there is no signs of angina in chronic coronary syndrome for patients undergoing TAVI, no PCI is the option except in left main or right coronary artery osteocyst lesions. What are the challenges that we meet specifically when we have a combination between left main and aortic stenosis with TAVI? The risk for hemodynamic compromise during left main PCI in the presence of severe aortic stenosis, or TAVR in the presence of critical left main stenosis. The interruption of the myocardial blood flow during the balloon inflation for left main PCI in patients with severe aortic stenosis can result in significant hemodynamic compromise with rapid deterioration in the cardiac function. Conversely, during the transcatheter aortic valve deployment, especially with rapid pacing or balloon predilatation in preparation for TAVI, this can compromise coronary flow in the presence of coexisting significant left main disease. Other challenge is the potential interaction between the coronary stent and the prosthesis due to the anatomical proximity of the left main ostium to the aortic sinus. Slight displacement of calcium nodules or aortic leaflet or plaque shift towards the left main ostium can result to left main occlusion, and in the presence of left main disease, and in patients with pre-existing osteo left main stent, the structure of the valve frame can deform the left main stent, impairing the coronary flow. The time of PCI of left main, we should consider the severity of the stenosis of the aortic valve and the left main, which is the leading cause for the patient's symptoms. Is it the ischemia or the severe aortic stenosis? We should consider overall the clinical stability of the patient, his comorbidities, and the presence of the symptoms. In the cases with pre-TAVI PCI, high-risk patients, usually these are the patients with high-risk patients with unstable coronary artery disease, with acute coronary syndrome, for urgent LM PCI before TAVI to stabilize the hemodynamics. In patients with significant left main disease, with syntax score more than 22, pre-TAVI revascularization may be prioritized due to the hemodynamic importance of the left main artery and its role to supplying a substantial portion of the myocardium of the left ventricle. Or for stable left main disease, we should consider it with the heart team and to choose the best strategy for the patient. After the PCI, one of the most important study actually is the CT, which is going to give us also information about the anatomy of the aortic root. It's going to give us idea for the strategy that we can use, the device what kind of device we should use, and also to show us potential reaction between the protruding left main stent inside the aorta. And with that, to choose the proper strategy to keep the left main from potential interaction, or to choose another way of treatment of those patients, or should we send to turn down the patient from TAVI and send him to surgery if the propagation of the stent in the aorta is too big. If we during PCI during TAVI, it requires careful planning to minimize the procedural risk, contrast volume, and ischemic time. Usually, it's used for patients with usually the delay in revascularization could compromise the patient's condition. Also, it's performed where there is high risk of left main obstruction during TAVI. The risks for the PCI during TAVI are usually larger amount of contrast and higher risk of acute kidney injury and prolonged procedure time. Risk factors for left main occlusion during the native valve TAVI are usually large prosthesis, larger ratio of the sinotubular junction to the diameter of the prosthesis, low coronary osteums, large sinus of the valsalva, and longer coronary cusp length. Usually, the strategy that it's proposed is to go first with wire through the left main, perform the TAVI, and with stent waiting in the aorta, and to check after the TAVI implantation if there is signs of occlusion and reduction of the blood flow through the left main, go for the fast PCI. Post-TAVI PCI, in some of the cases is unplanned unplanned urgent scenario, such as acute coronary syndromes or delayed coronary progression. It's usually with a low risk of hemodynamic instability during complex PCI. That's why some of the cases operators decide to perform first the TAVI and then the complex PCI procedure. Challenges include accessing of the left main ostium, especially in cases of transcatheter valve commissural misalignment or bulky valve frames. Left main PCI in the presence of transcatheter heart valve requires careful planning to ensure guide catheter alignment with the coronary ostium, particularly in self-expandable balloon, or if there is potential interference between the balloon expandable valves from the transcatheter valve structures. What we consider when we choose the valve for the transcatheter aortic implantation, we focus on the anatomical characteristics as sinotubular junction sinus height, coronary height, and the device procedural factors, such as if we apply commissural alignment, what's the height of the ceiling skirt, and what's the valve implantation depth. Usually when actually the most important thing for the coronary cannulation post-TAVI is the optimal implantational depth and commissural alignment of the device. There are different strategies for the different devices depending on the structures of the valves, but for all of them, the most important thing is the proper alignment of the coronary of the cusps and the proper depth of the valve implantation. With the decreasing count of valve TAVI and TAVI procedures, we are going to face additional challenges, such as cannulating through two transcatheter aortic valves, which is going to be pretty challenging. Of course, the main idea still is to perform all of the procedures step by step as first TAVI with the proper depth, with the proper commissural alignment. Second TAVI should be with the same proper depth and try to keep the commissural alignment as close as possible, so the cannulation of the transcatheter, the cannulation of the coronary arteries is going to be still possible, because especially when we have low coronary osteus below the nail skirt and with narrow sinotubular junction, it's going to be really hard to cannulate the coronary arteries. for every platform, for every transcatheter device, there is step-by-step way how to perform optimal commissural alignment, which all the operators know and perform. So we are going to have optimal effect of the commissural alignment, which is going to improve the overall hemodynamic of the valve. It's going to improve stability of the valve, and it's going to decrease the deterioration, but also is going to help us to perform PCI easily if that's needed. LM-PCI considerations for the technique. Stenting techniques should be tailored specific to the anatomical challenges posed by transcatheter valve, but also by the anatomy of the patient. Should be two-stent technique or provisional stenting. It's up to the expertise of the operator and the anatomy of the patient. Imaging guidance should be vital and should be used for precise stent sizing, deployment, and possible optimization of the stent. Of course, it should be considered temporary mechanical circulation in patients with unstable hemodynamic and with severe aortic stenosis. More practical tips for cannulating of evolute valves, because they're one of the hardest to cannulate coronary arteries. From Medtronic, they suggest to use Judkins left or Judkins right guiding catheter. Downsize the guide catheter with 0.5 centimeters. Aim for the frame waist and go coaxial. Use the guide wire extensions liberally and remove the guide wire catheter with a wire. Another tips are just consider transfemoral option, transfemoral approach. It's easier, but if it's not option, use preferably left radial artery. Consider orthography if we do not have TAVI procedural images. If TAVI was recent, we should think, and there could be thrombus in the aortic root, and if there is difficulty in engaging coronary osteomes, this could be due to the sinotubular junction height, sinusoval salva diameter, bulky leaflet, or TAVI commissural posts. There is a bit of evidence gap because we are working evidence-based medicine, and we rely on the evidence that's coming from randomized trials. There are a lot of trials with a lot of data for surgery versus TAVR, with LM-PCI versus CABG, but there is no randomized trial that compares SAVR and KBG in patients with significant left main aortic stenosis to PCI and TAVI. There are some registers that we can use for the data. There are the REVASC TAVI registry. It's not specific for left main, it's for all coronary artery disease, but there are some patients with left main there. The procedures there divided in three according to the timing: PCI before TAVI, PCI during TAVI, PCI after TAVI. The results show that PCI after TAVI shows a lower cause of death and stroke. All-cause mortality is also lower, and the stroke rate is also lower. But for the patients with left main, majority of the cases, they were treated before the PCI and during the PCI. 15% of the patients with left main were treated before PCI, and only 3% of the patients with left main were treated before PCI. There wasn't sub-analysis, unfortunately, and I do not know what are the actual results from that. But another registry shows that there are similar. This is again registry not specific for left main PCI and TAVI, but PCI at all, shows that there is similar mortality, in-hospital mortality, doesn't matter of the timing, similar gastrointestinal hemorrhage, similar higher, lower heart acute kidney injury in the PCI, but here I'm sorry. just to go back. The results are there is higher risk for acute kidney injury, acute readmission, and total hospital cost when there is at the same day, they're higher than the same day when there is PCI less than 30 days, and PCI more than 30 days has higher than the same day total hospital cost, but otherwise same day PCI and PCI before TAVI, they're almost similar as results. The TAVI LM registry actually is the only registry that I found that follows up patients with left main PCI and TAVI in 11 different centers with 204 consecutive patients. In the registry, they divide the patients in 3 groups. Planned LM PCI, which is PCI that's performed before TAVI, which is 167, and also just to go back, planned PCI during TAVI and before TAVI, and planned PCI, which is PCI emergently performed during TAVI or 24 hours before TAVI, which the occlusion and the ostium stenosis is related to the transcatheter aortic valve structures, and post-TAVI, which is performed due to advancement of the coronary artery disease. The registry shows first that there is no difference in mortality in patients with left main PCI and TAVI compared to only TAVI procedures. As you can see, there is the curves are almost identical. There was also no difference in 1-year mortality in the patients with protected and unprotected left main performed PCI, but there is significant mortality in 30-day follow-up and 1-year mortality when there is unplanned PCI during TAVI. And this, I'm going to repeat that the unplanned PCI is just due to interaction between the transcatheter valve and the left main disease, which is not predicted. The predictors for mortality after TAVI plus left main, for the predictors that from that registry were found for 30-day mortality is unplanned left main PCI, need for second transcatheter aortic valve, and acute kidney injury and need for hemodialysis. Predictors for 1-year mortality is unplanned left main PCI, second valve, acute kidney injury, and low body weight. As a conclusion for the registry, performing planned left main PCI before or during TAVI does not result in increasement in the risk compared to the TAVI alone. Outcomes after TAVI plus LM PCI are not influenced by the presence of unprotected or protected left main, the location of the stent osteo or non-osteo, or the timing of the left main PCI. Unplanned PCI is associated with increased mortality, 30-day and 1-year mortality. As a take-home message, coronary artery disease and left main stenosis in elderly patients undergoing TAVI is a common finding and requires careful evaluation and proper management of the ischemia. Prognosis of prior PCI in patients undergoing TAVI with coronary pathology is uncertain, and optimal time for PCI is still controversial. But we should use an individualized approach based on the patient's profile, characteristics, symptoms, preferences, as well as anatomical possibility for the procedure. Knowledge of various transcatheter valves, devices, and their structural and functional characteristics are important for the and potentially interference with the coronary osteo is paramount for the operators. Performing planned PCI before TAVI does not result in increasement of the risk of TAVI alone. Outcomes of TAVI plus left main are not influenced by unprotected, and protect the last are already told them. And thank you for your attention.